Hey Super Mamas, it's Dr. Joy here, and you are watching Delivering Joy MD TV. Welcome to Super Mama Sunday. We're continuing our series on the advances in detecting preterm birth risk, and today we're talking about a special test called the Fetal Fibronectin Test, or FfN. An FfN test can give us an idea as to whether or not you may be having preterm labor. We're also going to talk about some of those symptoms that you might have if preterm labor is occurring. So I know you don't want to miss this. Make sure you keep watching. All right, Super Mamas, let me run back this intro for Dr. Shania so I can drop her receipts, because my girl is highly qualified to talk to you guys about this topic today. So today I have a very special guest. She is like black girl magic on 10,000. This is Dr. Shania Siebels, and let me tell you a little bit about her. I've got her bio here. Not only is she a medical doctor, but she's also an attorney, y'all. So this is amazing. She's board certified by the American Osteopathic Board of Obstetricians and Gynecologists. She completed a combined medical degree as a doctor of osteopathic medicine and a Juris Doctor, which is an attorney. She went to the University of Medicine and Dentistry at New Jersey and Rutgers School of Law in Camden, and she now practices in Columbus, Georgia. She is near me, so when I have a patient who has a lot of medical complications or who needs, special high-risk care, she's who I use. She's my go-to, my guru. So I wanted to get the information straight from her today. So you are getting the best and the brightest when it comes to talking about this high-risk condition of preterm birth. Okay, Super Mamas, so let's jump right into today's topic. So I wanted to talk to you guys about the fetal fibronectin test. And Dr. Shania is joining us today, and I wanted to get her opinion on this, and we're going to talk a little bit about how the fetal fibronectin test is used, why we use it, and how it can help to detect preterm labor. So, Dr. Shania, I know that the fetal fibronectin test came out some years ago, and everybody was super excited about it because they were like, oh, yeah, we can do this, and it's pretty easy to do. Just about anybody can do it. We can get results fairly quickly. And I think that it kind of brought us a new piece of information. So, tell me, how you use the fetal fibronectin test when you're looking at moms who have preterm labor symptoms.
Sure. So I think, when patients have preterm labor symptoms, which for the patients out there, preterm labor symptoms can be a lot of different things. They can be the actual contractions that are coming frequently and painfully, but sometimes they're more subtle than that. It can be a change in the vaginal discharge, a larger amount of vaginal discharge. Certainly leaking fluid, clear, watery fluid can be associated with early rupture of membranes, but even vaginal spotting or having small amounts of vaginal bleeding can be a preterm labor symptom in terms of that. Pelvic pressure, vaginal pressure, rectal pressure, all of those things that are new or different or a significant change from what has been the routine for the pregnancy can be a preterm labor symptom as well. So you want to make sure you do either at least call your OBGYN or just go in to get seen and evaluated, especially if you're at a gestational age past 20 to 23 weeks of gestation. So once a patient presents, to the obstetric unit or the triage area with preterm labor symptoms, then as the physicians and providers, then we want to evaluate that patient. And the fetal fibronectin test is one of those ways that can help us gather information about a person's risk of actually having a preterm delivery. Fetal fibronectin is this protein that is normally there in pregnancy. But in normal pregnancies where there's no labor occurring and the risk of labor is low, the amount of that protein is very low. And so we expect the amount of protein to stay low for routine pregnancies. This fetal fibronectin is a swab that you can do, and it's a vaginal swab. It goes into the vaginal tissue, and we really want it to touch the cervix and get the cervical secretions there, because that's where you'll find this particular protein. And again, normally it should be in low amounts. The fetal fibronectin test is a very helpful test for us if it's negative. Because if they do the swab and they get the cervical vaginal secretions, and it is indeed found that there's a low level of this protein, that's really a 95+% chance that this individual will not go into preterm labor in the next 2 weeks. So that's very helpful for us, and it can be very reassuring for patients that even though the patient may have presented with some symptoms that were concerning, if the cervix is not dilated in a labor fashion and the FfN swab is negative, then we feel pretty good about that level of information to maybe send a patient home with precautions and reassurance. The swab is not as good if it comes back positive. Right. Because even if it's detecting a higher level of this protein there, the specificity of that result is just not as helpful. It's really anywhere from a 10% chance to a 40% chance that patient will then go into labor in the next 2 weeks. And as you can tell from those numbers, it's still more likely than not that the patient won't go into preterm labor. So when the FfN swab is positive, it is not as helpful. A negative swab is very helpful for us depending on the way a patient presented.
Mm-hmm. And that's how I explain it to patients. I was like, okay, if it's negative, that's great. We can kind of say, okay, we know it's not preterm labor, because those symptoms that you described are pretty non-specific. Mm-hmm. Increased discharge could be from yeast infection or bacterial vaginosis or a sexually transmitted infection too. So lots of things could cause that, or vaginal spotting could be from recent intercourse or from a cervical infection, or so many things could cause those things, but you always want to be on the lookout for preterm labor. So that test is very nice to help us rule it out if it's negative. And that's what I refer to as the negative predictive value. And that's the idea that if you have a negative test, that you actually don't have the problem that you're testing for. Yeah. So you have that negative test, the negative predictive value is very good, like Dr. Shania was saying. But the positive predictive value, meaning that if you test for it and the test is positive, the positive predictive value, or the actual you actually having the issue that you're testing for, is not very good with this test. So that's the hard part. It's like, if it's positive, it's like, oh snap, what do I do now? So what do you do if you have a positive fetal fibronectin test, Dr. Shania? Like, what do you do then?
Well, I think it depends on the circumstances, and we have to be clear about the fetal fibronectin swab. It should be done in the right fashion. And so we don't want patients doing this swab themselves. It should not be done blind. And I always encourage the triage areas that this is not a swab that is done blind. It really should be done with a speculum examination. The way I was trained when we were in residency was that any woman presenting with preterm labor symptoms less than 34 weeks, you got your swab table set up, and you did a speculum examination before you checked the woman digitally. Before you did anything else, you at least collected your FfN and some other swabs. And if we didn't end up sending them, then so be it. But we had them before we did anything different. And the reason for that is that you don't want the swabs to be affected by external vaginal secretions, bacteria that's normally in the vaginal canal. You don't want all of those things impacting your test. Blood impacting some of these tests, the fetal fibronectin or other tests for rupture of membranes, etc. And then, of course, if somebody really is in preterm labor and said there's a bag of water bulging into the vaginal canal, and you don't know because you haven't looked yet. If you're doing a blind swab, you may accidentally even rupture a patient. So I don't recommend doing the swabs blindly. And it's also important that we don't recommend these swabs in women who are not symptomatic. The swab should not be done just routinely in pregnancy to just provide reassurance in a woman who is not symptomatic. They're really made to give us further additional information in someone who is presenting with preterm labor or possible preterm labor symptoms. So when you have that evaluation, you want to know, after you've collected your swabs, we're then going to check the cervix, depending on what you're finding on your speculum examination. You want to check the cervix. Is the cervix closed? Are we 1 centimeter dilated? Are we 5 centimeters dilated? If the cervix is already beyond 2 centimeters dilated, or more than 80% thinned out, which means that the cervix is really thin, those are laborish changes that are occurring, and makes the swab much more likely to yield a positive result. And so in those instances, I'm really more likely to just discard the FfN results because they don't matter to me at that point at all. Now, what matters to me is the cervical examination. Are we detecting contraction, and is the cervix changing over time?
Mm-hmm.
If the cervix is closed or less than 2 centimeters and I have a positive FfN, then that's a really great place for a transvaginal cervical lens if someone can obtain it. Now, transvaginal cervical lenses are not available in all institutions, in all obstetric units, and especially they're not available at all hours of the day many times. And so sometimes it can be difficult to obtain that depending on where you are located. But certainly if you're in a resource abundant place and they have the availability to do the transvaginal cervical lens 24 hours a day, 7 days a week, then that is wonderful, because that then is very helpful in these equivocal situations where maybe you have a mom presenting with painful contractions, the cervix is closed, but the FfN is positive. So it's like, well, what do you do? Well, let's look at the cervical length, because if the cervical length is 30 millimeters or more, then the chance of that person going into preterm labor soon is less than 2%.
Awesome. And so I'm going to link that video in the cards up here where we talked about transvaginal cervical length. But I just want to make this clear. Transvaginal cervical length. Because I don't know about you, Dr. Shania, but it gets under my skin when I see people trying to give me a transabdominal cervical length. And that's where they put the probe on top of your belly and try to measure the cervix. I have had some people do that in the past, and the cervical length is very different when they measure it from on top of your belly versus using the probe that goes inside of your vagina. And the cervix can look very different. I remember being on call one night and receiving a report that the cervix was funneled and that the fetal foot was inside the vagina. And I was, it was like in the middle of the night, I jump up, I run to the computer, and I'm looking at the images, and I realized that I'm looking at transabdominal images. And I'm like, no, I ordered a transvaginal cervical length. And then we go back, I get the probe, and I'm looking, and I'm like, the cervix is perfectly normal. It's like like 40 millimeters. And it's not funneled, and the foot is nowhere, so like it almost gave me a heart attack. So I'm like, oh my gosh, you have transvaginal cervical length. And I think that's important for you guys to know, super mamas, because you need to, sometimes you have to advocate for yourself. I had a patient once tell me that I told them, because they were getting serial transvaginal cervical lengths in the office, and they went to the hospital because they were having these preterm labor symptoms, and they were getting an ultrasound, and they said, well, are you going to check my transvaginal cervical length? And they said, oh, well, we'll check it from above your belly. And the patient was very savvy and said, no, they always check it from my vagina, from when I go to my doctor's appointments. And I think that sometimes knowing those little tidbits can be very helpful when you're in a situation where you're having symptoms and you're worried about, what's happening with you. So now I wanted to just ask you a question, because first of all, you are the MFM, but when I was trained, we always did speculum exams. And then there was some literature that came out maybe 2015 or 2016 about not requiring speculums for the fetal fibronectin. And there was this big push to initiate the preterm labor assessment tool, which was a nurse-directed guidance to go ahead and initiate before the physician maybe even was on site. They would go ahead and do the fetal fibronectin, urine culture. They would get genital cultures, and they would initiate a time clock to recheck the cervix within 2 hours. And this was from the March of Dimes. Mm-hmm. So I wonder, like, I see the look on your face. I'm wondering like your opinion on that. So, because that kind of turned into like a big, there are order sets that were nurse initiated, and they kind of removed that speculum exam idea. But I never really thought about the fact that if the bag of water was coming through that cervix, like if you poke that Q-tip back there, you may very well rupture the bag of water. I never really thought about that, but it's definitely something to consider.
Yeah, I think part of those recommendations, and I think, when the March of Dimes, because where I trained for fellowship, the March of Dimes was putting together this whole preterm birth algorithm that they really, and a lot of it was for hospitals that don't have in-house physicians, in-house resident physicians. And so, yes, there is different sort of, I don't want to call them levels, but yes, you have to use the resources that you have available to you. And so if you don't have in-house physicians, there's no residents or anyone else that can do these speculum examinations for you, and you need an FFN, then yes, you may have to do what I call a blind FFN. That may sound a little bit terrible. It's not. We do other swabs vaginally without a speculum. So it's not wholly unusual to do that. But in particular, the FFN and the swabs for rupture of membranes are preferred to not do them blind. And, both the manufacturer of the FFN and the FDA recommend direct visualization and making sure that you are sampling the posterior fornix using a vaginal speculum. I'm sure you've seen before with some of these swabs, if you get blood on them, it can affect the accuracy of the results, especially the rupture of membranes ones. And again, you just never know. When people present with preterm labor symptoms, I've seen moms writhing on beds, but their cervix is closed. They are not in any sort of labor, And then you also see moms that come in with very mild symptoms that you're just not, you don't really think too much of it. You put a speculum in and you're looking at a bag of water, so you just never know. And so that's, to me, that's why with the speculum is, if you have the resources to be able to do that. But yes, when the March of Dimes came out, and we were looking at it within the healthcare system that I was working at the time, they were looking across all of their hospitals. And much of the hospitals that they were really addressing some of the issues with preterm labor assessment and management, because a lot of patients were just getting admitted and getting all these IV fluids and getting potentially unnecessary steroid courses and all these things that, and they didn't end up being into any labor, and, looking at, was that the right thing to do, or did we do the right thing? Was really looking at hospitals that don't have people available 24/7 to do a speculum.
And that was actually a hospital like me,
That's right, yeah. So in those cases, then absolutely, I think you do the best that you can with the resources that you have available to you. And, the FFN can still provide some information. It's not the ideal situation, but it is the situation that you have in front of you. So that's fine.
Perfect. So I think that was probably my misunderstanding, because I've always pretty much worked at rural hospitals where, we took call from home. There may be only one person in the whole hospital, or even in the whole city who was available. So like you may be managing everything everywhere, and when patients are coming in, it could be really difficult to get to everybody at one time. So we were a part of that preterm labor assessment tool rollout, and our nurses were, okay, I'm going to go ahead and get this FFN, I'm going to get this, I'm going to get that, and get everything cooking, so that by the time the doctor gets here, we're going to be rolling and we're not going to miss a beat on that. So, okay, that's good to know. I'm glad that we did consider resources, because resources are very different at a lot of different centers. So in terms of the fetal fibronectin, we're talking 24 to 34 weeks. What sort of assessment would you do for a patient less than 24 weeks?
Yeah, I think it depends on what their gestational age is, but and it depends on where you are, because some hospital policies are that if you're less than 20 weeks, you're going to the ER.
Right.
And so you might be evaluated initially by an emergency department or emergency room physician who's not an obstetrician, but usually if they have, clinical suspicion for, some preterm labor rupture of membranes, they're going to call the obstetrician fairly quickly. Most of our ER colleagues will.
Right.
They don't want to be doing those assessments themselves anyway. So, and then of course it depends on, again, your resource level. Like, is there an obstetrician in the house who can come and see you, physically in person or not? But, you can actually do the FfN swab as early as 22 weeks. And actually I encourage it as early as 22 weeks because nowadays we've got more information about this peri-viability, and we're doing more at that 22 to 24 week mark. So I would use it 22 weeks and beyond. Of course, that's assuming that you know accurately the gestational age, which isn't always the case.
Right.
So, but if we've got somebody less than that gestational age, then it's going to be all about a pelvic examination and transvaginal ultrasound if you have it available. So digitally examining the cervix, a transvaginal ultrasound can yield a lot of information about what's going on at the level of the cervix. Is it long? Is it closed? In terms of that on the digital examination or the transvaginal ultrasound length. And then you can still do the contraction monitoring for those patients and see if there's anything going on there. So you just don't have the same full gamut of evaluation modalities available to you when they're less than 22 weeks. But so you use what you have available.
And I just want to pause a second to speak to, because for a mom or a family, sometimes when there's preterm labor going on, and they are concerned about what's happening with their baby, they're wondering why we're not doing everything. If the baby is less than 23 weeks, or why we're not transferring them to a high-risk center with a NICU. Can you speak a little bit on that? Because I know sometimes that's really hard for folks to understand if the baby is not at a point where it can live outside of the mom yet. They feel like, I want everything done, or you guys are not doing enough to help my baby.
Yeah, that's a really difficult place to be in from a patient perspective, and of course from a physician perspective too, because we want to do everything for our patients to yield as good as outcomes as we can get from a pregnancy standpoint. But yes, when the gestational age precludes viability, meaning that the baby is not far enough along, has not spent enough time maturing in the uterus, that the fetal body cannot survive outside of the mom's body, we can't transfer to what one would consider a higher level of care, because hospitals and institutions have policies they have to follow, and a lateral transfer is what the term for that is, where there's actually nothing different that the receiving hospital can provide in terms of care for that patient based on their early gestational age, based on the obstetric condition. And so the transferring hospital can actually get a significant fine and incur penalties in terms of that. So it's important for patients to understand that medicine is limited, right? I mean, there's only but so much we can do, and we certainly can't make risks zero for anyone in pregnancy. And when we're at a pre-viable gestational age, especially anything less than 20 to 22 weeks, we're remote from viability at that point. A baby's body, the skin, the eyes, it's not developed enough that anyone can do anything if the baby is born. And that's a hard thing to tell a patient, and that's a hard thing, I'm sure, to hear as a patient.
Yeah.
But it is also important to understand that sometimes doing things isn't actually to the benefit of
Absolutely.
the mom or the baby. You can do a lot of things to a person's body, but if we're not causing good or we're not increasing positive outcomes, then we're just doing things, and that actually can create harm in certain situations. And so, it can be a very difficult situation and difficult to hear. Certainly, if someone feels as though they're not in that gestational age realm and something more should be done, I do encourage people to advocate and ask questions. And if you're not getting adequate answers or responses back from whoever you're talking to, you ask somebody different. Right. But certainly if we're, but it's not always because we don't care or we don't want to do anything. that there is nothing that can be done at this gestational age, and transferring someone to a different hospital, it's going to yield the same information in terms of some of those things. So it's just very difficult all around when you have those situations.
Right. So, like, for instance, Dr. Shania is my transfer center. So if I call and I have a patient that I feel, needs to be transferred, I call and explain that situation to her. And the reason that I would call her is that I feel that she can offer the patient something that I can't. And for me to be able to transfer to her, there has to be something that she has at her hospital, or a service that she has at her hospital that I don't have, that she can provide for the patient, or for the baby, via the NICU. And the main reason why I would send someone is either the mom has really high risk due to medical issues, or we have a baby that's under 32 weeks for my center, because we don't have what's called a neonatologist, which is a pediatrician that takes care of really early babies. Well, if baby's under 22 weeks or 22 weeks, the neonatologist is still not going to be able to offer anything to that baby. Therefore, it's not going to be beneficial for me to call Dr. Shania and say, hey, I want to transfer this patient who's having her baby at 20 weeks. So if it's not going to be beneficial, then she can't accept that transfer. So she's going to have to say, well, Joy, no, I can't accept that transfer unless there's a problem with the mom that she might be able to help with. So that's why, and I wanted to just kind of pause and say that, because I know that a lot of families struggle with that, and they wonder if we're not, that we just don't care, we're not interested. But these babies are so tiny, at that point. Their skin is translucent, their eyes aren't, fully developed, their lungs are so tiny, and even trying to put a breathing tube down to help them breathe, having instruments to be able to do that. It's just like Dr. Shania said, we're limited. And maybe one day there might be a way, but right now, today, we don't have it. And we often see these stories of people who somehow made it happen, and babies that survived. And those are miracles and great things to hear. And, of course, everything on the internet is true, right? But, and if you know somebody who had that, that's wonderful. But the reality is that it's very rare that babies who are that early are able to survive. And so I just wanted to pause and say that. Will you talk a little bit about steroids? I think that's another thing that comes up.
So steroids, and when we talk about steroids, there's these shots that we give to moms when something is going on with the pregnancy where they're higher risk to deliver early, and within the next 7 days, typically is sort of the thought process from our standpoint. And steroids are an excellent way to reduce neonatal morbidity and mortality. There's huge benefits for babies if they're born early. If the mom has received that course of steroids, it's 2 injections 24 hours apart. That's the full course. Babies do have improved outcomes if the mom has received that course versus babies where the mother has not received that course and are delivered early. And we try as best as we can as providers and physicians to try to time the administration or giving patients steroids when we think their risk is high enough that we should get this course on board, because the benefits for the baby are really best closer to the time of when the steroids are given. And what we find is that we're not very good at timing them, because they're, like we have talked about, there's a lot of signs and symptoms of preterm labor. We try to use all the information that we have talked about in terms of the fetal fibronectin, the cervical examination, the transvaginal ultrasound length, all of these factors we try to consider in terms of how high is someone's level of actually delivering the baby early. And we do okay with that, but we're not perfect. And we can't predict for everyone when they will deliver and if they're going to deliver early at all. Some women have high risk factors for delivering early, and they don't deliver early, and
Right.
and vice versa. So we try to time the steroids as best we can. We do okay with it across the nation if you look at the numbers, but we give a lot of steroids to patients that never go on to deliver early. And part of that is because many hospitals that provide obstetric care don't have some of the resources to obtain an FfN. So they don't have the resources to get all of this information, a transvaginal ultrasound for cervical length at 10 p.m. at night. They just don't have those things. And so they're making those decisions based on less information than some of the rest of us have, because we are in institutions where we're able to get those things much easier and more readily. And so the more information you have, the more things, I think the better we are at predicting who is who and making decisions about who can go home without steroids, who needs to stay for steroids, etc. So we do the best we can with the information that we have in front of us and try to time the steroids. Now, in a particular pregnancy, a woman can only get 2 courses of those steroids. So that's another reason why it's very important to try to be not so, judicious with just giving steroids to everybody, right? Because you want to make sure that you have the opportunity to give it if a delivery is actually going to occur, and so you don't want to just give out all your courses for one person's pregnancy and then not have it when you actually want and need it. So
you give it when you think you need it, and then say for instance that patient doesn't deliver, and then they come back several weeks later, and this time it really is game time, and you want to get a rescue dose on board. I will admit that if you're looking at the numbers nationally, I am probably one of the people who is more liberal with them, because I am at a center that does not have a NICU. And so I'm like, okay, I do not want to get caught with this preemie with, poor lung development, and we're going to have a problem. So I do tend to be like, okay, we just literally got an FfN capability last year or earlier in 2021. So, I was definitely much more liberal with the steroids, because we just didn't have all those pieces of information. We're just now kind of developing our ability to get transvaginal ultrasound all throughout, 24 hours a day. So, like what you're saying, in some of these more rural hospitals, we don't have all that. So we're just like, okay, let's use what we got. We got steroids, and we got exam and monitor contractions. So we're doing what we have capability to do. But I think the more information we have, the more judicious we can be. And so I think that's amazing. So I think that these are all like very helpful tips, and I hope that you guys learned something. I know I did. Thank you so much, Dr. Shania, for sharing your wisdom with us throughout this entire series, and we look forward to having you contribute in the future so you can keep all of us on track and knowledgeable about the latest greatest when it comes to some of these high-risk problems that can occur in pregnancy. We will catch you guys on the next Super Mama Sunday. Make sure you put your questions and comments below, and make sure you subscribe so that you don't miss a single episode. We'll catch you next Super Mama Sunday.